Tēnā koutou katoa and welcome to eHealthTALK NZ. I'm Rebecca Macbeth and I'm the media editor at HINS. Thanks to Third Age Health for sponsoring this podcast episode. I'm joined by Clinical Advisory Committee Chair and Geriatrician Jackie Broadbent, welcome Jackie, and Clinical Change Coordinator Madelaine Young. And we're going to discuss setting standards in aged care. So it's lovely to have you both on the show. Can you start by giving our listeners a brief introduction to the foundation standards, explaining how they operate within traditional GP practices and why this model needs adapting to suit services such as Third Age Health?
Yeah, sure. So for any of the listeners who have come from GP practice world, they'll be very familiar with the foundation standards. And so that was developed by the Royal College of General Practitioners, and that assesses the general practice and the service that they provide, and it gives minimum standards across multiple domains that they have to meet. And those foundation standards are designed for your traditional general practices that have a physical presence. But the service we provide is we send general practitioners and nurse practitioners into aged care facilities to visit patients in their home there. And so the service standards for a traditional GP clinic really don't work, as we don't have a physical building and we also practice in a really different way. The care that's delivered to the patient is very different, and we're also working with multiple different members of the care facility team, the patient, their family, and other sort of allied health that are coming into the care facility. And so we felt we really needed a standards that was specific to the service that we provide. And the traditional foundation standards, when you look at the domains, some we wouldn't be able to meet, and there are also services that we provide that general practices aren't able to offer. So that's why we looked at developing our own.
Perfect. So what gap did you see in the sector, Jackie, that really drove the development of the elder care standards?
The main issue is because of the unique working environment that clinicians who go into residential care have. The current framework, there was not an overall framework to support those clinicians, and there's a variety of different clinical systems used in that setting. So the facility may have their own, the practitioner visiting may have their own. And when we were looking across New Zealand, there's a lot of variety in how general practice services are provided into residential care, from perhaps a more traditional model where you might have a rural setting where the GP knows the person and has a good relationship from beforehand, and they just continue that into the facility, to perhaps a bigger facility in an urban setting where there may be less continuity. Third Age Health is unique in providing services across New Zealand for this, and we're seeing a lot of variety in how different teams worked. And I think also in residential care, there's a number of different stages covered. So a general practice service needs to be able to address routine, sort of day-to-day care, routine reviews, but also urgent reviews, after-hour reviews, palliative care needs, family meetings, working with visiting allied health. So it varies a lot, the structure and the way that care is delivered. Of course, individual clinicians' practice is governed everywhere by the medical council and the nursing council. But in order for third age health clinicians to be well supported in their practice, we felt the need to bring together all those governance standards in a single document so that everyone working in the space had the same understanding of how those needs would be met.
Certainly a complex environment. So why is it important then to hold medical organisations to this clear set of quality standards when delivering care in aged residential care facilities?
I think people expect medical care to be consistent and provided in a reliable way. And if you imagine, say, two people living in different parts of New Zealand. So say you've got Mary in a city and John is in a rural centre, and they've both got similar health conditions, something like, say, diabetes and heart failure, and they've both moved into aged residential care. Maybe they've had a change in their health state or a change in the way family can support them. I think people in New Zealand would have an expectation that the care is delivered in a similar, consistent way wherever that person is living and whatever the size of the facility. But what we're finding is that there's a lot of variation. So one person might see the GP fairly promptly. They might have that GP or nurse practitioner might have ready access to previous records for that person. And there might be a scheduling of routine visits and readily available after hours contact and care. But another person, say John, might find that things look different because the support structures around that clinician vary.
It's avoiding that postcode lottery that they talk about
Indeed.
in health, isn't it? So, Madelaine, what are some of the risks of practicing without a clear set of standards like this, particularly for older people living in care?
Yeah, so for older people living in care, if there aren't set standards for the medical care that they receive, there are multiple different people that are affected. There's the patient themselves. They may be, like Jackie's talked about, they may receive a different sort of care. They may have some delayed care compared to residents in other regions, but also their family will be impacted. It can be very stressful for them. Often when residents move into aged care for the family, it's a really difficult time. And so if services aren't provided consistently or aren't what they expected, it's hugely stressful for the family. And they also end up having to take on the role of advocating for their family, and that might be something that they're not able to do or find really difficult. Of course, also without clear standards, the facility staff can really struggle. They might not know what their patients are going to receive, what to do in response to an emergency, how to escalate things with the GP. So there's all different people that are impacted if there isn't a clear service standards. There's also, without that, limited oversight for how clinicians are practicing. And of course, all clinicians are responsible or held accountable by their kind of governing body, maybe the medical council, the nursing council. But it's also from the organisation. We need to have a set framework of what we expect of them and certain criteria that we want them to be meeting. The other risk, of course, for clinicians, if they're practicing without set standards, is they're at real risk of burnout or increased stress. They may be taking on more and more caseloads, working late in the evening, responding to every phone call themselves all the time. And that's just really not sustainable for a lot of people, especially if they're the only GP in a region for all of those residents. So have standards to support them will hopefully prevent some of that.
Yeah, workforce burnout is certainly a big issue at the moment in the health sector, isn't it? It sounds like a big project. What did developing the elder care standards involve from your perspective, Madelaine, at Third Age Health?
Yeah, so the project began in about 2020. We reached audit stage by about 2025. So that was about 5 years worth of work. And over that time, there was a lot of development of the standards. We had a lot of input from the PHOs. We also had a private quality advisor supporting us. We have our clinical advisory committee who also had input into the development. And we also got input from clinicians. And then, of course, the Third Age Health management team were all on board. So a lot of consultation went into it and a lot of trialing and looking at what this could look like until we got to the finished product. And we were able to be audited by an external auditor. We used DAA against our own standards, and we did that last year. And so it did take a long time, but it was the type of project you need a lot of expert consultation on and not something you want to rush. And especially in healthcare, things are ever changing. So we were having to redevelop it in kind of real time.
I can imagine you had to be quite agile in that space. So, Jackie, what would you say? What are the gaps that currently exist between the policy intent and what actually happens on the ground in practice?
So I think if we took, say, documentation as an example, I think you'll find a lot of variety in how people practice. So in one place, there might be GP notes might be entered directly into a clinical system in a facility. In another place, they might go into the GP's records in their bricks and mortar practice and then be copied across to the facility. There could be some delay. I think ensuring that there's consistency around that sort of thing. Another example, as Maddie's mentioned, is the after-hours care. So one place might have the GP themselves taking on the after-hours cover. Another, it might default to local emergency services or telehealth, but it might be a telehealth service that is not familiar with the patient or the facility. So we're just seeing a lot of variety around the country, and it would be good to bring in the governance structures around different ways of practicing into one way of working, particularly as third age health is looking to expand, and we will, I'm sure, see the similar challenges from other providers, and we think it's worth getting down in black and white so expectations can be aligned between the health provider service, the facility team, and particularly patients and families.
You're talking about, having to be agile before, Madelaine, and we know technology is always evolving rapidly as well in healthcare. So how's that influenced the need for consistent quality standards in this sector?
Yeah, so, there's been a lot of new technology that's coming about that's been really helpful and really supports our clinicians with their workload, but it, of course, also increases the complexity, and it reinforces the need to have a set standard for clinicians on how they can use these tools in a safe and effective way. For example, things like AI use for documentation is becoming more and more standardized. We're also using and increasing the amount of virtual care that we provide, and a lot of different service providers are now providing virtual options. We also have clinicians working across multiple different platforms and storing patient information across multiple systems. So, for example, one of our clinicians may go to visit a patient at a care facility. They will log into the facilities system where they keep their nursing notes. They may also log into a separate medication platform for prescribing medications. They will then also log into Third Age Health's PMS that we use to store patient records. They may then even go into other platforms to do things like referrals or check specialist letters. So they're working across multiple platforms. And so there's really a need to have a standard to say how they can do this safely and what are the expectations.
So does having so many different systems in play make it harder to gather the data you need for the audits and reporting then?
Data collection is still challenging, and it is still often quite a manual process, but at least having standards does allow for some consistency. In an ideal world, we would have all patients on one system, and that's your one source of truth, and you can get all the data you need from there. But unfortunately, we know that that's unlikely to happen. And so we're hoping that with the standards we have, we're able to work with what we do have and have a clear plan going forward of things like auditing, and we can enable some benchmarking with that.
And so what impact have you seen so far from implementing the standards?
Yeah, so we have just finished our first audit that happened last year, and it helped us. We got some really useful information from that, and we also had some areas that we thought we could improve on. And so that's led to the development of our quality improvement plan for the rest of the year, the areas that we want to work on. We've also had positive feedback from the PHOs and the GP College on the standards that we've developed, which is great. We've also had feedback from our clinicians that they really value having a clear framework. They can work across all different sites and feel safe working across different regions, and they understand the type of service that they are expected to provide, and they can feel supported as well. It also gives us improved communication with our care facilities that we're contracted to, so that at the time that we first on board with them, they know exactly the type of service that they can expect for us. We're also held accountable because we've got it there, what we want to provide and when. And so it's really improved that relationship. So another area that it's really helped with is our after-hours service. So Third Age Health, for some of our care facilities, we provide support overnight and also over the weekends. But when you don't have clear standards, that can often be difficult because facilities may not know who they should be calling, when to escalate things. The on-call clinician may not know who they can talk to if they need some advice. So having a a structured after-hours process and pathways that we can communicate with the facility as part of this project has been really helpful. And it's helped us to support the facilities and patients, and hoping to reduce the amount of reliance on the hospital system or other after-hours providers because we have a clear pathway.
So it sounds like it's really having quite a significant impact on the day-to-day work of clinician. And it sounds like you really co-designed with the GPs, clinicians and PHOs. Would you say that was key to the acceptance and the positive feedback that you've had?
Yeah, definitely. So our clinicians who are out there doing the work in aged care, they're the experts, right? They know what works, they know what their patients need, and they're the ones that hold the relationship with the facility. They develop those relationships with the staff working on the ground. And so we really valued their input. We wouldn't have been able to develop this without that. And same with our clinical advisory committee. We've got all different experts from different backgrounds there. And so we really valued their input in development of this.
So Jackie, what would you say about how the elder care standards are supporting clinicians and facilities and can continue to do that to deliver better care moving forward?
I think it's been useful to define what the expectations are working in this space from the point of view of people providing and also those receiving this care. It does recognise this area of practice as an area of expert practice within the general practice sphere, and I hope that that will lead to it being increasingly valued as an area which requires its own set of skills and also specific support structures around the clinicians working in this area. As Maddie said, I think there's a risk of burnout, and I think there's also a under recognition of the amount of work and the complexity of the work, and having structures around people working in the area helps us make that visible. I think also having really clear pathways around how people deliver that work, how to raise concerns, both from a point of view of ensuring patients have access to the care they need when they need it, and also improving continuity of care. So I think this has got the potential to do that. For example, if you are looking for some assistance after hours or urgent care, having a clear process and having the clinician at the other end of the phone and being able to access notes, see what's been done before, that's going to be really valuable. Historically, we've had perhaps more individual GPs, perhaps carrying that continuity in their heads with a long-standing relationship with a patient. And where you can access that, that's fabulous. But I think we're moving more and more towards team-based care, and that requires really clear documentation and processes to support high-quality care.
Yeah, particularly standards around escalating after hours into virtual care services. That's quite unique, actually, to have a standard pathway for that, as a lot of areas of health are moving into that. But I'm sure that there are all sorts of different ways of it working all over the country. So other sectors could learn something from what you've done as well. What do you think, Madelaine, about the future? What does it look like for the elder care standards?
Yeah, so like I said, we just completed our first audit, and that's given us kind of a starting point. Like I said, that's helped us to look at our quality improvement plan for the rest of the year, the areas that we want to improve on. And then we've also, we've got our ongoing rollout of our policies and procedures and education for our team. We want to continue to engage with the PHOs and other providers to hopefully support a wider adoption and also to show why these are needed. We fully recognize that the standards are going to need to evolve and adapt, and it may be, in a year and 2 years, we're not sure if things are ever changing, but we're very much aware that this is going to be a living document and we need to continue to improve. We hope that the standards can help to contribute to a wider discussion about the important service that is being provided in aged care, and how for these types of patients and for the facility teams, they need to have a clear framework.
And what about you, Jackie? If we're looking ahead a bit further, say 3 to 5 years, what positive impact could these standards have on aged residential care as a whole?
Yeah, I think residents in aged residential care and their families will be able to know that they're getting a good quality standard of care, that the clinicians coming in, the background things like that they've got cultural competency, that their documentation's all up to date, that will be done very smoothly and quickly. So they will know that those clinicians coming in have got all of the background, if you like, the administrative stuff has been done and it's documented and on file. That those clinicians visiting will be well supported, their time will be well managed, the facility will get good value for the time that the clinician is present in the facility.
Well, I look forward to hearing more about it in the future in that case, but we do have to wrap it up for today. So thank you so much for joining me today, Jackie and Madelaine, and thanks to Third Age Health for sponsoring such an interesting podcast episode. If you want to learn more about Third Age Health, you can visit their website, which is thirdagehealth.co.nz. Mā te wā.